So our next plenary talk will be done by Professor Theresa Busch. She's from the Department of Radiation Oncology at University of Pennsylvania. And one of her research interests is in the understanding of the biophysical limitations of PDT response. So giving us some important information to try to consider to how to overcome these PDT response limitations. So thank you, Theresa, for coming.
I wanted to start off with first thanking, the microphone, thank you. I wanted to first start off by thanking the organizers for both the opportunity and the invitation to come here today and share with you some of the work that we're doing. Just as a quick reminder, I'm going to mention right at the outset that PDT with traditional photosensitizers is dependent upon three different things, and that is the presence of the photosensitizer itself, the excitation of that photosensitizer with light, and the presence of oxygen in that tissue in order to create reactive oxygen species, in particular singlet oxygen. However, this said, it's also well known that tumors have a very heterogeneous microenvironment. This is characterized by hyperpermeability, leakage of dye into the tumor area, presence of hypoxia, labeled here with a red hypoxia marker that's stained with immunohistochemistry. And that hypoxia is present between the blood vessels. However, the blood vessels are frequently absent, leading to avascular strips, or they may not be perfused, leading to unperfused areas within the tumor. May even have characteristic abnormalities in the structure of their basement membrane. For example, abnormalities in collagen deposition. Why should we be concerned about this pre-existing vascular microenvironment in PDT? Basically, it's because the things that commonly characterize the microenvironment, including the vessel density and perfusion and permeability, they can affect all components of the PDT reaction. It's obvious how they can affect oxygen concentration, showing again here the presence of hypoxia between the blood vessels. They also are going to affect factors such as your photosensitizer uptake. So here, this is an animal tumor in which there's an avascular area and that drug pooled, photofrin pooled in that area. But it's also an area that was anoxic. So actually that, although it looks like there's a large amount of photosensitizer there, it actually is doing no good. These characteristics can even affect the penetration of light in the tumor. And that's because at the wavelengths that we use for PDT with photosensitizers such as photofrin, so right here at the 630 nanometer illumination, there's differences in the absorption of oxy and deoxyhemoglobin, and that can lead to attenuation of light as a function of the oxygenation of the tissue. That said, we can't overlook the PDT-altered microenvironment. PDT can substantially change local tumor physiology, and this has been shown by us and many others over the years. This is an example of how, over the course of PDT, and this is just over the course of illumination, vasoconstriction resulted in the blood vessel here constricting, and thus it's no longer visible in this confocal microscopy. Blood flow can vary significantly over the course of PDT delivery, so this shows large increases in blood flow initially upon beginning of ALA PDT in clinical studies. And of course, these changes in vasoconstriction and blood flow can lead to the presence of a hypoxia, where the hypoxia here is labeled just during the course of PDT. So severe hypoxia, indicated in red, accompanied by less perfusion, where the blood vessels that are perfused are labeled by green after injection of a dye in vivo in the animal. So how can we take into account the vascular microenvironment when we're doing studies of PDT? The first approach is to measure. And then as I'll get into in a few minutes, based on these measurements, we're now starting to modulate. So as I already mentioned, PDT produces a prominent hemodynamic reaction during illumination. And this is a trace that's characteristic of illumination with photofrin PDT. These are studies that are done in collaboration with Arjun Yode at the University of Pennsylvania, where diffuse correlation spectroscopy is used as a non-contact, non-invasive optical method of measuring relative blood flow over the course of PDT and then the time thereafter. So everything is expressed relative to the few minutes before PDT is begun. And as I already mentioned with photofrin PDT, there's a characteristic increase in blood flow followed by a decrease. These changes, these increases and decreases, can vary from mouse to mouse. So why would we want to monitor it? And that's because it's predictive. So in these animal studies, we can show that if we characterize the flow reduction rate here, it is predictive of the time it's going to take for a tumor to regrow to 400 millimeters cubed. And this is our endpoint, 400 millimeters cubed, that's equivalent to survival of the animal. It's the time at which we would euthanize the animal. And what this shows is that if the flow reduction rate is steep and the blood flow drops very rapidly during the course of treatment, then the time it took for that tumor to regrow is very quick. However, in another animal where the blood flow dropped more slowly over the course of PDT, those tumors took much longer to grow, out to 25 days to grow. Similarly, we can also show that PDT induces variable changes in oxygenation, measured as tumor hemoglobin oxygen saturation, abbreviated as either SO2 or STO2. However, again, these are measurements, the characteristics of the tumors are very variable. So in this group of animals, most of the animals were relatively well oxygenated, or at least had higher levels of STO2, although there were several that had very low levels of STO2. These are exactly the same tumor model, grown to very closely to the same size, treated with exactly the same PDT conditions. So right after PDT, in most cases, STO2 increased slightly. However, in some cases, STO2 decreased. And then at 3 hours after PDT, there seemed to be consistent decreases, which would be consistent with developing vascular damage. And again, these measurements at the level of the individual tumor are predictive. So if relative STO2 is calculated, and basically that's a value that takes in the STO2 immediately after PDT relative to what it was before PDT, so it's calculated as a ratio, that ratio is highly correlated with the time it takes for a tumor to grow back to 400 millimeters cubed. Higher values, longer it takes for the tumor to grow back. Lower values, more quickly it grows back. And these are findings that are generalizable throughout the PDT community. There's been a number of publications showing through various methods of measuring oxygenation or blood flow during and after PDT that it can be used as a predictive measure of outcome. And this extends to even newer technologies such as photoacoustic imaging, and it's been consistently shown over the years. So now the question becomes, we can measure tumor physiology and we can measure tumor hemodynamics. How do we use those measurements? And what I'm going to talk about next for just a few minutes is modulation based on those measurements, and in particular, modulating the delivery of the PDT light. So the premise here is to use monitoring to inform modulation, and we're calling it real-time hemodynamic-informed PDT. The underlying idea is to use the real-time information based on the hemodynamics to actually adjust the illumination parameters for PDT during the course of the light delivery. The idea is to start out with a higher fluence rate at the beginning of treatment because that is a quicker treatment, which is very clinically favorable. But since low fluence rate conserves perfusion, based on hemodynamic measurements, lower the fluence rate as needed in order to maintain hemodynamics above a certain threshold, which I'll describe a little bit more on the next slide. So this comes from a publication we did quite a number of years ago, which shows that the perfusion at the end of PDT, if one treats with 75 milliwatts per centimeter squared, is reduced. It's significantly reduced to what was found in the tumors before PDT. And these are just measurements made at different parts of the tumor. But if the fluence rate is lowered, in this case it was halved to 38 milliwatts per centimeter squared, we can maintain that perfusion. So that was the rationale for starting out with high fluence rate and reducing it as needed. And of course, in order for this to work, it's going to require integration between the hemodynamic monitoring and the light delivery. So this is the system that we built. This work was again done in collaboration with Arjun Yode's lab in physics. The non-contact probe for diffuse correlation spectroscopy is shown here, connected to its module. And now this information that's being collected is providing feedback to a digital attenuator. And that digital attenuator is placed in front of the laser. So it's modulating the output that's going to reach the microlens that's being used to treat the mouse. And these are studies that we have recently initiated, but we've tested a few conditions that's done in rift tumors with photofrin PDT, and a light dose was always set to 135 joules per centimeter squared. And then we treated 3 different fluence rates. One, the whole treatment was at 75 milliwatts per centimeter squared, no attenuation. Second, the whole treatment was at 25 milliwatts per centimeter squared, again, no attenuation. And then in the third group, the light started out being delivered at 75 milliwatts per centimeter squared, but then it was attenuated as needed. And these are the data that were collected and visible as the study was taking place. The top plot here is the plot of relative blood flow. So everything is normalized to these few minutes here before PDT began. And then once PDT began, that's marked here by the vertical line, and as characteristic of photofrin PDT, there was this increase in blood flow. The second plot is plotting the slope, and that's shown in red, of the change in blood flow. And then the dotted blue line is indicating the threshold for the change in slope that we would allow without triggering an attenuation. And that threshold was set at a value of -10, the percent change in relative blood flow per minute. So as the blood flow increased here and then started to decrease, this decrease led to a decrease in the slope that resulted in the slope passing the threshold that we had set. At this point, the fluence rate, which is plotted here, automatically lowered from 75 milliwatts to 50 milliwatts. And I should mention here that the treatment was always maintained at 135 joules per centimeter squared, which means that as this decrease occurred in fluence rate, the programming automatically calculated how much longer treatment would need to go on in order to deliver the desired fluence. So at the point that this crossed the threshold, blood flow, the light attenuated, and now you can appreciate that blood flow started to recover. So it started to come back up. So the threshold came back up, it crossed the line again. Now our slope is above the threshold. However, a few minutes later, the same thing happened again. So blood flow had recovered, now it started to drop again, it crossed the threshold. At that point, now blood flow dropped from 50 to 25 milliwatts per centimeter squared. Again, the amount of light that was needed, the amount of time that was needed to reach 135 joules per centimeter squared was recalculated in order to maintain the total dose. And then throughout the rest of the treatment, there were a couple of close calls here, but it never actually crossed the threshold. So the remainder of treatment went on at 25 milliwatts per centimeter squared. We allowed for one additional attenuation as part of the system down to 10 milliwatts per centimeter squared if that was needed. So these are our early results showing the effects of attenuation. And basically, in order to assess what its vascular effects were, we just continued to measure blood flow through 1 hour after PDT. And then this plots relative, this indicates, in a representative animal, relative blood flow at 1 hour after PDT, which again is calculated as this time point relative to what was present in the same animal before PDT. At 75 milliwatts per centimeter squared, I'm looking in the middle here first, the change in blood flow at 1 hour after PDT was very small. There was very small change from baseline. However, if the light was attenuated, it was significantly greater, and there was a 50% reduction in blood flow at 1 hour. And then 25 milliwatts was intermediate. So this is suggesting to us that there are vascular effects of adapting this attenuated system based on the hemodynamic monitoring. Now, looking ahead, the idea would be to do this sort of thing in the clinic. And I'm going to change gears a little bit because here, what I'm going to describe is a technique called reflectance fluorescence spectroscopy. Most interested for this particular talk in the reflectance spectroscopy, which a system designed and built by Jared Finley in Department of Radiation Oncology. We use this probe in order to measure the oxygenation of lesions in a trial of early stage premalignant head and neck cancer. So this trial was a dose escalation study of total light dose, but a fixed fluence rate, and light doses varied from 50 to 200 joules per centimeter squared. It's a trial that's been carried out just recently closed, been carried out by Peter Ahn, Harry Kwan, and Keith Sengel at Penn, although Harry's moved on. Eligibility criteria included erythroplakia with dysplasia, severe dysplasia, carcinoma in situ of the head and neck, and focal microinvasive carcinoma, so it had to be limited in its depth. Patient characteristics. These are patients that we analyzed first coming out of this trial because they received fractionated light. And really what we mean by that is that there was a break of 90 to 180 seconds after 20% of the dose was delivered. And the reason we pull these patients out to analyze first is because this break in light allowed us to use the diffuse reflectance spectroscopy to measure oxygenation during PDT. So we could use it to measure oxygenation before, during, and at the end of PDT. And these patients well represent those that were treated on the trial. All different histologies. Sites were those sites that were accessible to the probe that we needed to use, so include a lot of tongue, buccal mucosa, floor of the mouth. These are the results of the STO2 measurements. I'm going to point out that they'll come out soon in publication in photochemistry and photobiology. And I want to remark here how similar this looks to the types of measurements that we found in the mice. That is, many of the patients had reasonable levels of STO2. However, there were a few who at baseline had low STO2. Again, PDT created changes. So this is the measurement made during the fractionation, the light-off fractionation period. So PDT did create changes both before and after PDT. Here we didn't follow out to 3 hours because the patients were no longer in the operating room at that point, but these are made immediately after PDT. And the interesting thing here, which we describe in this paper, is that in these patients, all of them had a complete response at 3 months, except for these two, the two with the lowest STO2 after PDT. And clearly it's too early to do any correlations or anything like that with this limited group, but this is something we're going to look at much more carefully as we expand these studies to include the whole group of patients that was treated. So to summarize this part of my talk, PDT-induced changes in tumor physiology or tumor hemodynamics are predictive of tumor response. We've shown that in mouse models. Very importantly, we can measure them in the mouse models as well in the clinic. So that allows us to take these possibilities of making predictive measures into the clinical setting, as we're starting to do for the head and neck trial. And back in the lab now, we're adapting mechanisms in order to adjust PDT delivery based on the actual measurements that are being made. So then for the last few minutes, I wanted to turn into another approach towards modulation. I've described measuring tumor physiology, measuring hemodynamics. Modulation, we can modulate the actual light delivery, so we're doing that during the course of PDT. But there's also ways of modulating, prior to PDT, the sensitivity of the blood vessels. And really, this comes out of a study that we did looking at inhibition of the epidermal growth factor receptor. Epidermal growth factor receptor, or EGFR, is expressed in the cell membrane, and with its activation through its downstream pathways, it leads to things such as cell proliferation, inhibition of apoptosis, angiogenesis, so really survival signaling. And we know that EGFR is activated when PDT is performed. So this is immunohistochemistry of tumors treated with BPD, PDT, showing in the green here that EGFR is activated throughout the tumor and in the blood vessels after PDT is performed. So we designed a study in which a small molecule inhibitor of EGFR, Erlotinib, was given to the animals 2 days before, 1 day before, and on the day of PDT. And again, this is BPD, PDT. And then the animals were subsequently followed for their tumor response. I already discussed some immunohistochemistry, did some in vivo imaging for vascular responses, and some flow cytometry for cell death. So one of the first things we noted is that the addition of Erlotinib to PDT on the schedule that I've indicated led to very large improvements in tumor response to PDT. We went from a 16% complete response rate in H460 non-small cell lung cancers if PDT is given by itself, or 15% with another non-small cell lung line, A549, and that went up to 63% when Erlotinib was added, or 51%. But Erlotinib by itself had no effect. So we looked at tumors that were collected 1 hour after PDT by flow cytometry for their viability, and found that there was no reduction in viability in the PDT treated, in the Erlotinib and PDT treated versus the Erlotinib, let me try that again, in the Erlotinib and PDT treated versus the PDT treated alone, which is shown in the light blue. So that tells us that Erlotinib is not benefiting immediate PDT-induced direct cell kill, but there is this differential at 18 hours, suggesting to us that there is some sort of delay or indirect effect. So we went on to look at vascular responses. In these studies, animals were given an IV injection of a fluorescent dye at different time points after PDT, and then they were imaged 15 minutes later. At 1 hour after PDT, both a case of PDT and Erlotinib versus PDT alone, there's big increases in there's a lot of hyperpermeability, big increases in dye accumulation over the course of that 15 minutes. But here, by 4 and 18 hours, there's dye exclusion in the animals that received the Erlotinib and the PDT. So by 18 hours, there's 50% less uptake of the dye in the tumor in the animals that were received with Erlotinib and PDT. So we took this information, we went back to the in vitro setting and looked at how sensitive endothelial cells are to the addition of Erlotinib to PDT. And here it's apparent that there's a significant decrease in the viability of endothelial cells when they are pre-treated with the Erlotinib as opposed to just receiving the PDT by itself. So everything holds together, but really is that the whole picture? If we go back into the literature, it's known that inhibitors of tyrosine kinases can increase cellular uptake of many photosensitizers. It's been shown across different cell lines. It's been shown across different photosensitizers. So is this the effect that's accounting for our improvement when we add Erlotinib to PDT? We went and imaged the mice for uptake of BPD, and in the presence of Erlotinib, there was almost double the amount of BPD in the tumor as well as in the flank. I'm sorry, these are a bit washed out, but there is a lot more BPD taken up in the tumor here compared to if there was no Erlotinib present. So this could account for the improvements in tumor response when Erlotinib is added to PDT. But we wanted to know if this was it. Does this account for the whole thing? And I'll remind you that this was 3 doses of Erlotinib that was given. So what we did is we instead just gave the mice 1 dose of Erlotinib. And if they're given 1 dose, this does not increase photosensitizer uptake. Yet, it still does a very good job of improving PDT response. So a 16% complete response rate with PDT 63% with 3 doses of erlotinib and PDT, so this is accounting for vascular effects, this is accounting for increases in photosensitizer. But if we get rid of those increases in photosensitizer, we can still get a 48% improvement, a 48% cure rate or complete response rate. So what are some of the clinical considerations when we're combining EGFR targeting with PDT? Well, one of the first things to point out is that when it's added to PDT, as it was in these studies, it mediated large improvements in therapeutic outcome, even in tumor models and in tumor cells that were resistant to erlotinib. So it's an approach that, in our experience, could be used even in erlotinib-resistant models. Some other things to think of are that the dosing consisted of only 3 doses given in 2 days. Normally, erlotinib is given as a maintenance therapy over very long periods of time. So this is a substantially reduced cost for use of erlotinib. It's reduced potential for acquiring resistance to erlotinib, which happens in many, many patients. Also, many patients develop side effects to erlotinib, and it actually results in many of them having to come off the therapy, and there's reduced potential for that since it's only 3 doses. And it's feasible in the intraoperative setting with PDT because although it's an oral drug, we're only giving it before the PDT. So there's no need to deliver it when the patients are in the ICU after surgery and PDT, which would be difficult. So in conclusion, measuring and modulating tumor microenvironment can be used to increase sensitivity to PDT. We showed that monitoring the microenvironment can help enable personalization of light delivery, but molecular targeting drugs can also be used to enhance the sensitivity at the outset of the tumor vasculature. Individualization of PDT delivery based on these microenvironment characteristics is going to be increasingly important if we want to help PDT keep up in the era of personalized medicine. So I wanted to acknowledge members of my lab, especially Shannon, who performed the work with erlotinib. In Arjun's group, Malavika and Wesley, together with Joanne, did most of the studies, the newer work on the hemodynamic monitoring. And of course, our support through the NIH. Thank you very much.
Thank you, Theresa. Questions?
Very nice, Theresa. I just had a question about that head and neck cancer data that you showed. So this is, of course, very consistent with our own work, you know, that you cited with the theranostics. I wonder if in that you got any sense of the level of response with the quantitation that we found, you know, which is anything less than 10% change in the oxygen saturation was incomplete. But, you know, you don't have enough patients, but I just wondered if at a first analysis, do you see any kind of a threshold that's needed?
In other words, a relative value. It's a great question. That's exactly something that we intend to look at when we're looking at the whole cohort of patients.
Right.
But unfortunately, we have not looked at it yet for this smaller cohort.
And the increase is sort of unusual that you noticed, right? In that one patient, there's an increase in the...
Everyone always points out when they see that. We do have that one patient that has that very large increase and then a decrease at the end. And that does seem a little bit inconsistent with the other patients. So as for right now, we don't have an explanation for it. We don't know if it had something to do with the way that the measurements were being made. I can tell you that we did go back and look at all those data, and we can't find anything actually wrong with the data. So there's the possibility that it was something that, you know, biological that happened in the operating room, including maybe it not being perfectly aligned.
Can I do one more question with that? Yeah, quick. So just one, I'll talk to you offline, but did you measure the whole lesion, or was it just parts of the lesion? Because that could explain it.
Yeah, exactly. They're point measurements on different parts of the lesion.
So if that's a permeable part, you might be getting a cellular effect.
Exactly.
Okay.
I'm really sorry we are going to just have these questions, but I'm sure Theresa will be here around for the other conference day, so you can guys reach her. Thank you very much.
Thank you.
And thank you guys for coming.